like to ask Gilles the very first question.
Thanks, Professor. Has any of your research centred on the role of nutrition? And what's your opinion on the role of nutrition in the whole process of recovery or surviving?
So, frankly speaking, we haven't worked that much on nutrition. It's clear that there are some indications coming from clinical trials that on the extreme side of what we call the body mass index, which means patient with very low body mass index or patient with very high body mass index don't do as well as the other ones. My personal clinical impression, and again, maybe that's not substantiated by strong data, is that patients with very low body mass index, which may be for some of them patients with unadapted nutrition or something like that, don't tolerate well the treatments. And for patients with a high body mass index, it's a little bit unclear whether it's tolerability of treatment for some of them, but it's also maybe inadequate dosing of drugs for others. So that's a general statement about health status when disease occurs. We haven't worked on any dietary supplements or things like that. Having said that, we have a paper which is in press in GCO regarding a very common element assessing nutrition status, which is vitamin D. So you may be aware that there are a couple of papers coming recently suggesting that patients with low levels of vitamin D have an increased risk to develop a couple of cancers, including lymphoma. And what we have shown with a collaboration with a group in the US, so it's both an US and French research, is that for patients with low-grade lymphoma, follicular lymphoma, patients with low levels of vitamin D had poorer prognosis than patients with optimal numbers. Having said that, first of all, I am not sure that in Australia, given the sun exposure, even if you are protected, that there are so many of you that have a low level of vitamin D. But having said that, we had this very amazing observation that if we compare the French population and the US population, there were differences in the median level at the onset, and because there is supplementation of vitamin D in the US in milk and things like that, patient had medium levels that were higher than the French population. That was amazing. I didn't know that. And we had a hard time with the paper because of that. But so that means that probably there are some nutriments and there are some vitamins and things like that which are essential to the body and to the function. We don't know much. I think, as Judith mentioned, having an equilibrated food and regular food intake is important. What I should probably warn patients about is, I don't know if it's common here in Australia, it has been taken in some part of Europe, it are all these aspects on diet, but strong diet, like being on no food intake, for instance, 1-2 days before chemo and things like that, or thinking that if you don't eat, you will avoid the growth of the cancer. Usually it doesn't do very good for patients. So I think having some equilibrated food, I think it's general advice, but going on very specific exclusive diet programs, I don't think this is very good. But that's what I think, without any proof.
Yeah, I would totally agree with you there, Gilles. Just further to the vitamin D story, I think we just have to watch this space as well, because, and particularly you men out there, before you start going supplementing yourselves with vitamin D, I've come across an expert quoting that high vitamin D levels increase the risk of prostate cancer. So, I think we really, really need to, see what the vitamin D story, how that pans out further. But certainly we would want everyone to be having optimal, normal vitamin D levels when undergoing therapy for their lymphoma. I also think that one particular nutritional aspect that is often neglected by patients when they're having their lymphoma is when patients are on the chemotherapy regimen CHOP with the prednisone. There are some people who, were a little bit pre-diabetic beforehand, and then the prednisone, I see a couple of nurses here in the audience nodding very, very much, because they're seeing this on the wards. As soon as people are on steroids, the prednisone, for 5 days, their blood sugars can often go quite high. And that needs not avoiding not avoiding food, but, liaising with their treating doctor and their GP about how to optimise their blood sugar management in that 5 days while they're on the prednisone. Yeah, but I think also too, maintaining a good dietary intake and keeping your weight up is absolutely crucial. When you get diagnosed with lymphoma, that's not the time to go on a weight loss diet, that's for sure.
Well, actually, that was interesting regarding recovery. I always tell patients, you cannot fight several things at the same time. And after having gone through chemo or through a treatment, well, I prefer to have patients gaining 2-3 kilograms more than usual, rather than asking them or telling them that they should maintain their ideal weight. And I think they will take care of that 2-3 years later. I don't think we can handle everything in our life at the same time.
Yeah. And I've had a patient who I've watched and waited with low-grade lymphoma, and then he came back with this terrible, terrible weight loss and looked quite cachectic, and I was very worried. But there were no other signs of the lymphoma progressing, and this was just quite out of keeping. And then I discovered he was on this incredibly strict, pureed, vegetables-only diet, and, it can be very dangerous. I'm sorry, we just got the one microphone. I'm sorry, we're trying to repair the second microphone. So if you don't mind passing it down first to the lady in the black and white here, and then passing it back to yourself, John, and then we'll go along to the man in the blue. Thank you.
My question is, I have mantle cell, and I find it very confusing because it's the borderline as well as high, as well as high grade, or acts like low one. Is there any new information about mantle cell, any clinical trials specifically for mantle cell?
So just to repeat the question is about mantle cell lymphoma and the fact that, yes, we are with some mantle cell lymphomas that behave like really indolent low-grade lymphoma and other that behave like aggressive lymphoma. This was probably not well understood for quite some time. I mean, 25, 30 years ago, we said it's low grade. Then we realized that patients that developed disease aggressively were rather refractory to low grade treatment. And we started to treat patients with more aggressive regimen with quite progress that were, very substantial progress that were made. But then a couple of researchers identified a subgroup of patients had an indolent disease. I should say that unfortunately in our trials we don't distinguish those. I have even seen patients as for second opinion with mantle cells that were advised to go on a trial with high dose therapy and transplant, and saying, well, I think you have this kind of indolent form of mantle cell. Let's keep you on watch and wait for quite some time. And what has been shown by this group of researchers from New York, and I think reproducibly experienced by some physicians around the world, was that for those patients with very this feature of indolent mantle cell, which are usually involvement of blood and spleen but no lymph nodes, delaying start of treatment is the right option. Unfortunately, I should say that different from follicular, where we can have watch and wait for many, many years, I feel that most of these patients at some time will have to be treated, and probably treated aggressively. But I think it's good at this time of the year, or at this time of the time we are living, to keep patients in watch and wait with indolent form, because given the variety of new agents that appear to be effective in this disease, they may come at a time where they may benefit better from this new agent.
So I think the concept of watch and wait, the most important word there is watch. And I think when you watch and wait, you don't say to your patient, come back and see me in 6 months' time. All right? I think that the follow-up has to be tailored appropriately for the patient, and the patient needs to be educated about what symptoms and signs to watch out for. I think it's specifically to your question in terms of clinical trials, the frontline treatment of mantle cell lymphoma has traditionally in Australia, for most people with mantle cell lymphoma, given that the average age is about 65, was rituximab and CHOP chemotherapy. Professor Rummel's data has seriously challenged that, and many patients in Australia participated in a study called BRIGHT, which is replicating Professor Rummel's trial, and the data from that trial is not yet mature yet, and that will be very important, because we generally think, the one randomised controlled trial is fantastic. 2 randomised controlled trials in of the same style are fantastic, even better. So a number of patients participated in the BRIGHT study comparing rituximab and bendamustine with rituximab and CVP or rituximab and CHOP, but we don't know the long-term outcome of that study. But more recently, a number of patients Australia-wide have participated in the SHINE study, where they were randomised to receive rituximab and bendamustine plus ibrutinib, this enzyme inhibitor, which is a very well-tolerated tablet, or rituximab and bendamustine alone, because increasingly it is felt that, particularly for mantle cell lymphoma in the older patient population where transplantation up front is not appropriate, that rituximab and bendamustine is a very good frontline therapy. But that trial has now closed to recruitment, and obviously that will also take years to get the answers from that study. But certainly ibrutinib is also shown in clinical trials to be very, very effective in the relapse setting of mantle cell lymphoma, but we need longer follow-up.
I see many arms raising, so I think we have to keep our answers
Sorry.
short.
Oh, no. Where's the microphone?
The microphone is here, but there are questions here and on the back.
If a autologous stem cell transplant is given, what risk is there that malignant cells will also be transplanted?
I'm sorry, can you speak a little bit loud?
If a stem cell transplant is given, what risk is there that some malignant cells may also be transplanted with an autologous transplant?
So the question is interesting. That's especially in low-grade lymphomas, what is the risk when we do autologous stem cell transplant, which is a transplant with your own cell, to reinfuse some malignant cells? In theory, this risk is always present. And I should say that in all low-grade lymphoma, we don't expect that autologous transplant cures the disease. So it's one procedure of treatment that usually lowers substantially the amount of tumor cell in the body. And even if there are some cells in the autograft, maybe they don't rehome well, they won't divide well, but except in the very few patients, usually there is still a benefit of using that. So the question of not having a pure graft is in theory it's important, but in practical terms, it doesn't change much the result. Very briefly, in the early 90s, we evaluated some device to purify the graft. This has stopped because all this purification led to more complications, especially more infections in patients that went through. And it didn't, at least in, okay, it's different in multiple myeloma, but in 1 or 2 trials didn't show any benefit. So it's unclear what's the role of these so-called contaminating cells.
Thank you. I've got low-grade follicular lymphoma, and I'm not really sure what low-grade means or what follicular means, but my question is, energy levels are more clear, but my energy levels don't seem to be what they were before. Is it just because I'm 3 years older, or is that common?
That's a difficult question. I think how we live with the disease and how the disease change our lifestyle and charge our energy and things like that, it's I think not easy to assess. I will say that on the patients I know that are under watch and wait or watchful waiting, I haven't seen many patients complaining about these changes. For patients that have been treated with chemo, whatever chemo, and even sometimes rituximab alone, yes, there is some side effect and there is some impairment of quality of life, which may include the level of energy you feel. So unfortunately, that's something we still don't know how to handle that, and probably developing less toxic treatment will help.
Where's the next hand? Perhaps someone who's close to the gentleman in blue so that they can
That's
grab
the lady.
Oh, we've got a second one, have we? Okay, go ahead.
Professor, this morning we heard that bendamustine is 50 years old. Is there anything in the trials that show that this drug causes some cardiac problems?
No, that's one major benefit of bendamustine as compared to CHOP. In CHOP we have adriamycin, doxorubicin, which is this red compound, which when used at higher dose or repeated dosing, not like 6 courses, but maybe 8 or more, or in a few patients even with limited courses, can lead to cardiac toxicity. I don't think there have been any reports that bendamustine can cause cardiac toxicity so far, and as far as I know.
Professor, can you have bendamustine multiple times and a relapse? And if so, is there any potential to damage stem cell with a future transplant?
So, yes, if I understood well your question, can we use bendamustine in relapse patients? Yes, actually, we use it. And in France right now, and actually in Europe, the situation is that, but France may be a little bit particular, it's not approved in first line. So we are not in a very different situation from you. But it's approved as a relapse treatment for follicular and other indolent lymphoma, so use it quite a bit. Regarding stem cell damage, I think Professor Rummel, which has the most experience with that, will say it doesn't damage stem cell. And I think he had proposed autologous transplant to a few patients in his trial that went through fine. I and others may have a little different opinion on that. I haven't used much bendamustine in patients that will undergo transplant, but I have at least 1 or 2 patients in my mind from my practice who had delayed engraftment or delayed platelet engraftment or low platelet counts after transplant. And because of the mode of action of the drug itself, there is a rationale to think that it may a little bit damage stem cell. I think maybe one word of caution. I think as shown clearly by clinical trials and randomized trials, it's much better tolerated in terms of incidence of leukoneutropenia, infection, and so on. But there are a few patients, especially when given in relapse, that have really low blood counts and develop leukopenia. And then you should be very careful to stop at 4 courses rather than 6, because in some patients then you have really profound and substantial neutropenia for quite some time, which is something usually you don't encounter with other agents, except for diarrhea.
Could we pass the microphone forward?
Since follicular lymphoma reoccurs or reappears after, say, 1 or 2 years again, and I had 3 relapses, I was wondering, as it cannot be got rid of totally, can I manage it through some oral medicine or something that I take for my blood pressure? I take a regular medication. So why can't I control this?
Well, that's a very interesting debate we have scientifically, is that should we aim to treat this disease as a chronic disease like diabetes, like high blood pressure, or should we aim to cure the disease? And I think it's a debate within the medical community. What I should tell you is we have an observation right now in patients with newly diagnosed follicular lymphoma. Whatever the burden of lymphoma and whatever the ways they were managed, watch and wait, rituximab in US, rituximab single agent is frequently used, or rituximab plus chemotherapy. If the patient has a result of this treatment that led to no disease recurrence or no progression for more than 1 year, the survival expectation is parallel to that of this population without lymphoma. Meaning that if the disease is quiet, either without treatment for more than 1 year, or after treatment, the treatment remains efficient for more than 1 year, then it starts to be a very chronic disease, even if it recurs, that doesn't seem to be associated with an increased risk of death. So that's a quite new observation that is made by 2 cohorts of patients from Mayo Clinic and Lyon. And I think it recapitulates some other observations made by others. So it helps identify probably a subgroup of patients, which are the ones who progressed early or resist to therapy or for which therapy, in which probably we need to aim for more efficient treatment. So that answers a little bit the question of prognosis and chronicity of the disease, which I think is very important. Oral medication, some of the kinase inhibitors that we mentioned, these drugs that target the enzymes, are being developed for that. If I should say the truth, I don't think that the drugs we currently have, first generation of these compounds, will be drugs that are tolerable for a long time period with controlling the disease. But maybe second generation or third generation will do it.
There's at least one patient in this room who's hoping to prove you wrong.
Sorry?
I said there's at least one patient in this room who's hoping to prove you wrong. But I would agree. I would agree.
Yes, always.
Hi. I've chosen not to take treatment for a low level of lymphoma with unusual side effects. And so I did a lot of research when I made that decision. One is that I understand that for my particular illness, rituximab had a low level of efficacy. But also that I thought that at early treatment stage, rituximab didn't have early efficacy. And that only after you've had some repeated issues that it becomes effective. So I've also therefore followed up things like epigenetics, where things like diet and exercise come into play about, basically about cellular biology, cellular metabolism, how you process sugars and things like that. So I've been reading about that and trying to follow a regime about that. But the curious thing is, I know at some stage I probably will have to go down a treatment path. The question is, where do you think the efficacy of that treatment part is?
I have no idea, and I cannot give, during this conference, any personal advice on that. I do think that it's fine delaying treatment as long as patients have no symptoms, as long as the disease burdens remains quite limited. And this is true for follicular, but also for other indolent diseases. We talked about mantle cells, but it's true also for some mild lymphomas and so on, or small lymphocytic lymphomas. That's true in general for all low grades. At a certain stage, there is a decision to be made, and I haven't heard that patients that have been on watch and wait in which we start treatment have a dismal outcome as compared to those in which treatment was started immediately. So it's just, each patient is different, and some patients don't need treatment, but treatment remains efficient at the time it started.
And if I can perhaps respond to one question you had in your comments there, I think the best outcome from any treatment is the first time you use it. Whether it be rituximab, whether it be bendamustine, yes, you can reuse those agents. Ideally, the longer you've been in remission, the more likely they're going to be effective again for a long period of time. But generally speaking, if you're reusing an agent, it will get shorter and shorter effects, duration of effect.
Although, again, there are patients in this room.
There's always exceptions,
That will prove
absolutely.
the opposite, but that's all right.
Absolutely. And that may be the synergy when it's combined with new agents, such as rituximab combined with the lenalidomide, for example. So it's harnessing and interacting with the lenalidomide. No, that's a very good point.
Professor, my question is in relation to second line defence. So with low-grade follicular, can you comment on what second line defence treatment is? And I understand that Europe is probably leading the way in second line defence treatments for low-grade patients with relapse.
So the question is, what is the optimal second line treatment? Can I summarize like that?
Yeah.
Well, it depends on a lot of things. I don't think we can say a general statement, that's the best second line treatment. It depends on the first line treatment, on the efficacy of the first line treatment, of the duration of the efficacy, on the age of the patient, on the expectations you have in life, or you and your relatives. And so there are many things. There is one point which is very important that Julie Trotman mentioned earlier, especially in patients with folliculars. This is true for other indolent diseases, but especially in follicular, there is one event that is important, which we call transformation. This event is the fact that even if you have indolent disease, low-grade disease, sometimes, probably because there are new mutations in the cell, the disease recur as a high-grade lymphoma. So if the disease recurs, and especially if there are symptoms or it recurs rapidly and so on, undertaking a new biopsy is important to identify that, because then the treatment of choice will be a more aggressive treatment that may include transplant. If this is not the case, I think it really has to be discussed as individual basis. I will say that a patient relatively young, physically in good shape, with a relatively what I would call early relapse, so not resistant disease, but relapses in 2 to 5 years of, for instance, rituximab CHOP, with some symptoms at the time of relapse, not like a lymph node that is enlarged from 1 to 1.5, but really lymph nodes of 3-5 centimeters. We should discuss transplant. I think that's an option that needs to be discussed. But I have seen patients of mine who didn't follow my advice and didn't want to get transplant, which are fine. So there haven't been any formal demonstrations that this is of real long-term benefit. It's just, if we look at the series of transplant, it's probably one of the treatments that provide the longer treatment-free intervals. That means even if it's harsh, even if it's the hard way to go, it provides a treatment-free interval that is longer. Again, it doesn't cure, at least autologous transplant. So that's part of the discussion. In maybe allogenic transplant is something to be discussed also in younger patients or patients very fit that are ready to take a risk of a more difficult treatment, but that also can give some benefit. Other than that, anything can be discussed, from rituximab to watch and wait to chlorambucil, bendamustine, and any options can be discussed case by case.
And it's very fortunate we've got this plethora of options to give, appropriate individualised treatment. Now we've got 5 more minutes. The lady at the back. Who's got the microphone?
There's lady at the back and lady at the front.
If you have the
It's a time of the ladies.
Please use it if you have it. Oh, there we go.
I've just been asked to ask on
Can you close?
Sorry. Her daughter has non-Hodgkin's lymphoma, and she just wanted to know how it differs from other lymphomas. And also, we were talking about the benefits of good food. Are there anything in particular that need to be avoided because they're carcinogenic and can impact non-Hodgkin's lymphoma? That's the question here.
So I think regarding nutrition and food, as we mentioned already, I mean, again, it's better, I think, when we have these patients have this disease, not to change too much their habits and not to change too much their lifestyle, unless they have a very disequilibrated lifestyle when the disease occurs, and alcohol consumption or things like that. But rather keeping things not very different from what it was before, it's probably important. Taking into account that with chemo, steroids, and so on, sometimes you have to equilibrate the way you live. In terms of carcinogenic drugs, I don't think there is a carcinogenic intake foods. I don't think there is a demonstration of things like that. I didn't got the first part of the question.
I think we might have to just limit that person to one question in the interest of time. Okay. We've got 3 more minutes left, I believe. Go ahead.
Yeah, I wanted to know in terms of side effects, which ones we should keep a close eye on, thinking about permanent, in terms of them becoming permanent. So tingling, burning, for example. I mean, I'm currently worried about the burning sensation that is not going away, and I don't know whether I should be worried about that with something that,
I mean, it depends on the drugs people receive, but with vincristine, which is part of CHOP or CVP, yes, when you start to feel limited sensation, numbness in your fingers, you should discuss with your physician of drug dosing adaptation, eventually lowering the dose for the next courses, or even keeping out vincristine from the regimen, because if it's continue to develop, you can have a neuropathy, so damaging your nerve with long-term long-term disabilities.
How do you know when that's likely to become permanent?
Well, I think it has to be, those have to be managed adequately when there are some symptoms that are permanent and start to increase. So if there's limited symptoms, what we call grade 1, that's okay, we can continue. But when it starts to be grade 2, when you have some burns or pains and or daily actions start to be difficult, then the drug has to be, if not diminished or stopped. And you have really to discuss that with your physician. This is something I tell my patients. I said, well, this is something maybe when you come back in the hospital, the resident or the doctor may not really think. So be careful. If it happens, bring that back to us as a consideration.
And watch out for constipation. No. It creeps up on you with vincristine, doesn't it? That's another. Yeah.
So just another question. What's the latest research on vaccines like BioVax?
Well, that's a very interesting question, and I mean, follicular lymphoma, like other indolent lymphoma, are a model in which we really did hope quite a bit that we can develop a way for vaccine which will be given to patients who had developed the disease but who may, after getting into remission, develop a specific immunity that will prevent recurrence. So there are 4 randomized trials that have been run, and except in some subgroups in 1 or 2 of these trials, it doesn't seem that the long-term benefit of this vaccine has been established. 2 of the trials are fully negative, and 1 is positive in 1 subgroup. So I don't remember. BioVax mentioned that they have nice phase 2 data. It's difficult, it's cumbersome to make the vaccine, and I think at this time we haven't really succeeded to get an efficient way. It's a little bit a pity because in theory it will be good, but that's where we stand, I think.
I think we're going to have to wrap up this. Maybe we just finish with this one last question. Thank you.
Can I please ask about the role of interferon in recalcitrant lymphoma subsequent to treatment in CVP and also in RCHOP? My husband's been receiving interferon for 2.5 years. The tumours have not changed in dimension at all. I'm just wondering what you think about him keeping with the interferon A2 uses.
Well, our group in France was involved very early on. Actually, it's one of the founding clinical trials of the group of using interferon in combination with chemo. So I do know that interferon is active, and at this time when there were no other immunotherapy, it has proven to be efficient in some patients in combination with chemo. As a single agent, it's really unclear. The major difficulty is that interferon sometimes provoke a lot of side effects. But if it's well tolerated in a patient, and if the disease is not moving, and if your physician feels that there is a benefit, and you are not harmed by this drug, I think it's not bad to continue. That's maybe a personal expert opinion, and like you said, personal expert opinion are not always very good, but I think it's a drug that has been proven to be active, and it's not a drug that we should throw away, even if it's not used a lot.
Absolutely, especially if the patient is tolerating it well and responding. Why would you stop?
Stabilizing.